Out there. Good morning, everyone. I hope everybody can hear me okay. We will get started as it's now 10 o'clock. Welcome everybody to the fourth of DRNI's webinar series on brain health and dementia. Thanks so much for joining us at the slightly earlier time of 10 a.m. today. So my name is Vanessa Moore. I'm the Scientific Project Manager for DRNI. And today's webinar, our fourth out of a total of 5, is on post-diagnostic supports. And we're delighted to be joined by Cathy McHale from Tallaght University Hospital and Áine Bennett from the Alzheimer Society of Ireland. Before I hand over to our speakers, I just want to remind everyone again that we'll have time in the end for Q&A. So please put your questions in the chat box, which I'll enable it in a minute. It's been disabled. Or in the Q&A box. They're both at the bottom of your screen. So just put your questions in there throughout the presentations. You don't have to wait till the end. Just post your questions as they appear. We'll hopefully get to them all at the end of the webinar. So I'll now introduce our first speaker, Cathy McHale. Thanks a lot, Cathy, for taking time up from a very busy schedule to be with us today. Cathy McHale works as a registered Advanced Nurse Practitioner in the Regional Specialist Memory Clinic in Tallaght University Hospital. She holds a bachelor's degree in English and Psychology, higher diplomas in Computer Science and in Safety, Health and Welfare at Work, a diploma in Gerontological Nursing and a master's in Advanced Practice from Trinity College, Dublin. She's worked across many nursing specialities, including end-of-life care, intellectual disability and the acute setting. She's worked for over 15 years in care of the older persons with a special interest in dementia, delirium, brain health and the humanities, and involved in the Specialist Memory Clinic established in 2014. She's contributed to national working groups on delirium and frailty and to a national integration group for the Alzheimer Society of Ireland's Dementia Adviser service. Her current role includes the assessment of patients, including neuropsychological screening and delivery of post-diagnostic and brain health clinics. She contributes to the research arm of the Tallaght University Hospital Memory Service and is part of clinical trial activity there. So that's a whole lot of stuff. No wonder she's so busy. I'll hand over to you now, Cathy. The floor is yours. Sorry, Cathy, you're on mute there.
Thank you so much, Vanessa. I hope that you can see my screen. Are you seeing my screen?
We can't see it yet. We're seeing your web browser, so you might just need to go into the presentation. Just to the PowerPoint. Yeah, that should do it.
Apologies.
You're grand.
So it's really an honor to be here today. It's a topic that's very close to my heart, and I suppose a huge thanks to Dementia Research Network Ireland for inviting me to speak, and hopefully I will be able to, hopefully enlighten people a little bit about what we might offer to people post-diagnostically. So I thought it would be very useful to go backwards and think about the way that we understand dementia in order to, I suppose, understand a little bit better how we can actually support people. And I think the other way that I think it is important to look at dementia is from a very person-centered point of view. So how do brain changes guide our support plans? And I'll just give a little example of that within the time that we have. Obviously, I can't cover all of them, but just some important components of post-diagnostic support and some signposting that might be useful to other services. So to start with, and we've all seen these infographics, there is a huge global awareness of the impact of dementia, and the numbers are stark really, but there's a growing awareness of what we need to do as well, and across the world there are plans in order to try and make life easier for patients and families. The World Health Organization have identified dementia as a public health priority, and we see all these areas: risk reduction, awareness and friendliness, health information systems, the research and innovation, which is what this is all about really, care support and diagnosis and treatment of patients who live with these diseases. So just, I suppose, a quick look at literature. Post-diagnostic support is often fragmented and fragile. There are barriers that we all know of, such as lack of coherent pathways and limited knowledge of services. and there's a lack of sharing of information systems sometimes. There is evidence for benefits of some interventions, and I'll go through a few of those later on, but it's very difficult to know what elements work, and so when we look to research, it's hard to really ascribe an impact from one particular aspect. We do know multimodal is definitely the way that works, as with brain health. So I think what informs our understanding of dementia is very important. What is it that we have in front of us, and what is it that this person is dealing with? And I thought it would be just interesting to look at this from I suppose, a broad point of view. The first thing that we do to actually understand dementia and the person sitting in front of us and what they'll need is we look at the disease subtype that they have. And this has become an increasingly important aspect to dementia care. And so a very busy slide, but I wanted to show really on the left side a diagnostic criteria that's very defined. And this is for Lewy body dementia. And on the right side, an example of an assessment toolkit that we might use on the ground, which actually just reminds us of all of these features, and it sort of keeps us anchored in what the disease really is. And we do get a little bit of this narrative that if you go into the hospital, nobody will recognize it. But actually, just for reassurance, we really do know what these diseases are. We're forever evolving our knowledge about them. And certainly maybe the first tier of staff that you meet may not understand something very rare, but you eventually will get to the right speciality. The next thing that informs us, I suppose, is research and guidelines. So we really are very lucky to have a huge body of literature around guidelines around people living with dementia, and they guide us as to what we do, and they inform us, and studies come out and they show us how these diseases behave in large groups of people and in small groups of people as well. So the patient experience, will that tell us everything about somebody's dementia type? Will it tell us everything about, for example, Alzheimer's disease? No, not really. But it is extremely important that we take it into account. And the reason that it doesn't is because everybody is so individualized. They come with their own comorbidities, they come with their own brain health, they come with their own subtype of dementia, and medication side effects, their insight levels, all these things will make a difference, how the person copes, and their psychological health. So, extremely important that we listen to the voices of all of the patients, but it is also important to understand that every person has a different experience. So experience of family is also another component that I think is extremely important. And I picked Terry Pratchett's literary agent, Rob Wilkins, as an example of somebody who walked the walk, I suppose, and was with him from time of being friend and colleague up to being carer, and as just, I think, touching on and informing us of the way in which these diseases evolve, really. And we have families talk about this all the time, that there were always explanations and signs. And in his case, he was premorbidly very scatty and clumsy, and he would have misbuttoned shirts and t-shirts inside out. And for anybody who doesn't know, he was living with posterior cortical atrophy, which led him to have a lot of visual issues. And so there was a sense, I suppose, that he was describing that it wasn't just the things he did, it was actually the way that he reacted to his mistakes that were very telling. So signing a book at a signing, looking down and seeing his letters all jumbled, missing a number on his keyboard, accusing him of stealing it, and the sound of fingers tapping was very evocative, I think, whereby he wouldn't be able to hold a cup with one hand anymore. He had to use both, and he would tap the desk to see if it was still there. And so these are the things, able to really clearly say visual acuity and topographical management, but he wasn't able to navigate a stairwell. He wasn't able to go through a revolving door. So these are very important insights. Clinical findings, just reassurance. We do very, very extensive battery of tests on patients, say very early bloods. This will be done often at GP level. And we've got a very clear model of care that lays out exactly how we work people up and how we decide what type of dementia they do have. So bloods, memory tests, neuroimaging, history and MDT review, and also biomarkers. So we would do CSF biomarkers to associate proteins for Alzheimer's dementia. So we can see how heterogeneous and complex it is, extremely so. And every patient that comes into us, these components will be they'll be very important, and aspects of them will be very, very different. And we do hear patients saying, to us sometimes that they want a roadmap, and families want a roadmap. And in our family care group, this comes up all the time. Families really do want something. They know that potentially it's hard to say exactly what will happen, but they do look for something. So sometimes just giving people, what this won't be. It won't be, a sudden dip. Alzheimer's is very insidious. All of those messages are very important. So the model of care in Ireland, obviously won't go through this in detail with the time I have, but 100% is asking us to do all of the things on the right, which are, individualized, tailored advice and support to be given in verbal and written, that the person be signposted to a dementia advisor. And we have Áine here to talk about that in a minute. A named point of contact, 4 to 8 week follow-up, and access to social work and MDT for all young onset dementia patients under the age of 65, and that we would have a care plan, and that focus on care planning is really, really come to the fore across the world. So the 5 strands of post-diagnostic support are there on the right, and always underpinned then by these beautiful qualities really, and focuses. So citizenship, person-centeredness, integration, and being really focused on personal outcomes and timeliness of care. So for the purposes of today, I wasn't going to go through, you have a whole document where you can look at the model of care. It's so rigorously laid out. But I think from my end of things, maybe just a little bit of practice from the ground, instilled, a little bit of research, and I just, my thoughts really, I suppose, on what might be useful. We always have to look, I think, at what the context of the person and their family is. So how long has it taken them to come through? Have they been from service to service? And hopefully with the new model of care, this will be less frequently happening. Patients will have localized services, but information exposure as well. Alzheimer's disease, have they been looking at 7 stages of dementia, which are just horrendous really, and all of this stuff is cobbled out on the internet, and they're looking at this and they're putting themselves into boxes that we really don't see on the ground. For the most part, a lot of these, if you look at these things, the first 3 stages are often nothing at all. They're actually just normal aging. So there is a lot of messaging that is quite damaging. The stigma that we get from looking at I suppose the cases we see in the media of advanced Alzheimer's disease, that brings through with people really. And people are service weary sometimes, they're afraid, they have anxiety, and they possibly have a positive family history as well. So identifying and managing needs is really important, that it's timely, that it's not rushed, that we're giving clear messages, that we're focusing on abilities and strengths, because we spent a lot of time doing memory tests and asking people to tell us what they don't do anymore, and focusing on what people cannot do. And it's all about just turning that on its head. What can people do? And tailoring to emergent needs, because it isn't a linear process with people at all. And I think what's most heartening is the 2-room approach, especially in our model of care. It's so important in dementia care that we have got an ability to talk to families separately and to talk to the person on their own as well. With consent, obviously, we do this piece to look at their pharma and non-pharmacological options, and to really make people, to set them up to be as well as they can be, looking at their medications, looking at vascular risk modification, and we're doing all that really early, and that they have an explicit plan really, and a point of contact person. So post-diagnostic review should be 4 to 8 weeks is what we would say in our model of care. And this is where we really have a chance to touch base and see what people understood, looking at their insight. And so a person with an anosognosia coming in with their family is going to be really different to a person who is really worried about their memory. And so these are different pieces that we have to navigate, and we're checking the understanding of what they've brought with them from their previous session. Are there any, the referrals that were made, where are they at? How to tell people comes up a lot in these sessions. And I think it's important to say it's normal to be distressed. It's normal to have the emotions that they have. They're very universal emotions. This should be flexible. It should be holistic. It shouldn't just be about the side effects of donepezil or the side effects of any medication. And we should look at mood as well. So do brain changes influence the support we offer? I think they very much do. For example, with posterior cortical atrophy, we're going to be dealing with a lot of visual symptoms. People, with simultagnosia, people who are having issues reading, they can no longer distinguish left from right. So there's all of these kind of very defined symptoms that are happening. And key signposting would be occupational therapy, to look at the environments that they're using at home and in work. And memory technology resource rooms are going to be absolutely crucial. Counselling, because we do see mood-related issues with this subtype of Alzheimer's disease, and on-road driving assessment. We'd look to Dementia Adviser, absolutely, and we'd look to as well to sort of signpost someone to brain health optimization, feeling well, and also just movement really in general. And we'd refer to the NCBI as well for supports around, supports that are available, grants that are available for visual issues. So yeah, it does matter. Frontotemporal dementia is going to be a totally different landscape. You're going to be talking about, potentially with behavioral issues, the family being focused on in terms of the support. So it's really important to tailor it. So we're checking that they understand information that's been given, and we're giving verbal and written information in the language of preference. We make sure our information is accurate and up to date. We're telling people what type of dementia they have, and things like free dem films, a really nice way of showing people what dementia is and brain health. And we're looking at pertinent issues for that person. So falls prevention, research opportunities, and we're looking towards driving as being important for a lot of people. So the steps, there is a really nice document from the Alzheimer Society that outlines this, and we've just photocopied that for our clinic, and we give that out to patients, and it gives them these steps, what people need to do. On-road driving assessment is indicated, and they do have to notify their insurance company and the National Driving Licence Service is where they go. Emotional psychological well-being is key. So I think it's such an emotive journey for people, and it's important to give the family and the person the opportunity to engage with peers. We look towards counselling. Anxiety and depression can be very, very, very high, and tailored purposeful activities will be key. I could spend all day talking about all these things, but with the background in arts, I really just think cultural quarter is like the best place you can send people, looking at a painting, going for a coffee, engaging socially, feeling alive, feeling good. It's also important. But there's a burgeoning piece around this now: social prescribing, cookery, meditation, and the joy of singing and music, and asking people what their favorite song is. And I need my camera in here for the rest of that, but it's very important. So non-pharma, I won't go into this in detail because it happened, last week was very much covered in detail, but cognitive stimulation therapy is very important, and it's a very the Lancet Commission would say that we should be giving these interventions to reduce cognitive decline, improve quality of life, cognitive rehabilitation as well. Reminiscence therapy, there's an update from the Cochrane review recently, just looking at that. So the research has gone up. The effects will vary. It depends on how it's given, and it depends on whether it takes place in the care home or in a community. So we really need more research, I suppose, on these non-cognitive interventions. I think in terms of exercise, there's a big piece coming next week, but we do know the effects in terms of prevention of dementia, but we also know that there's a lot of positive effects from exercise, and it's something that we definitely would be advocating our patients do. We refer them to medical exercise programs, and we try and make sure that they're getting out and about. So practical supports, Dementia Adviser, public health, Meals on Wheels, and I will send my slides along to anyone who wants these. I know there's a lot of information, but things like linking with Community Gardaí, disability badge, seniors alert scheme, all of those things are just vital. Future needs, future planning is going to be so important. Social work referral and linking to social work. All patients who are diagnosed under the age of 65 will be automatically referred to social work, and it is so important to get that forward planning piece done. And there are some fantastic resources out there to navigate people through EPAs and all of the legal pieces that they need to think about. There is a dearth of age-appropriate supports for people who come through under the age of 65, and they have obviously extra issues going on. They have got obviously a lot of the time dependent children. They have issues trying to talk to their children, and there's an employment impact there. So it's extremely important that we send these patients to signposting to citizens information in TRIO offices to talk about specific employment benefits. And Family Carers Ireland is an excellent resource as well for these patients. We also should be talking about the role of TUSLA and illness cover and those sort of issues. They're the things that they're going to need to know going forward. So the family member, time-wise, I hope that I will try and speed up a little bit. We really need to listen to the lived experience of the family And we're targeting the same advice to them, you know, their brain health, their connectedness, their self-care. And we're looking towards giving them face-to-face education as much as is possible. They should go away knowing what delirium is, knowing how to prevent it, you know, simple measures like preventing constipation, preventing dehydration, non-cognitive symptom management. You know, it is giving them tools to feel like they have some control. It's extremely important. We use this in our family care group. This is the de-stress study. It was done a number of years ago, 2017, and it's really impactful. And it shows people, listen, you need to look after your own health, because you can't be any help to the person if you're not well yourself. And there is a big link between depression, supporting someone who's living with depression or dementia, I should say, and depression and anxiety. So we need to get those messages across. These amazing resources alone, we do a lot of alone befriending, referring. This is absolutely phenomenal, and it's amazing for people who are living with behavioural symptoms, particularly, to get the family member out, to get them out and about, and to get the person supported. Memory technology resource rooms all over the country, absolutely phenomenal resource. Supportive memory guide, you know, there's just so much out there, really, and this is OT fueled, so it's obviously going to really be focused on allowing people to live well and using simple, smart and smartphone technology, for example, to live well. The emergency care plan, I think it's important that people know about this. We do it in our family care training. This is if the person goes away, they can nominate 2 people or goes away or is unwell, is unable to deliver care, that a nominated person will be contacted and 72-hour plan put in place. Really amazing stuff. The HSE stress control program, we refer families to this as well, and it is free. And Family Carers Ireland have these amazing resources around EPA and decision making. So useful signposting, I mean, it's a nightmare out there. There's a lot of things I don't send families towards. I have to be honest. I really just always make sure that it's bona fide and that the information is valid and it's not going to be, you know, in any way tainted. But there's so much happening in Ireland. I have to say, I'm so hopeful about the future. I mean, there's just if you're on Twitter, there's just so much going on. There's just wonderful initiatives across the country, and I really do think that the model of care, you know, as it is evolving, is going to change the landscape of care in Ireland, really. And this, you know what, we're also unique. Families are also unique, and it is really about empowering the person to live well, to find out what they love, what do they need really to live out the last part of their life, and it has to be individualized and it has to be person-centered. So listen, I'm going to stop now. I could just go on and on and on, and I do, but my references, I need to actually, I had a glitch, and I will be